Thank you for the kind introduction, Dr. Grover and Dr. Usha, and very good afternoon to all of you here. So, as they have said, we are going to talk about retinoblastoma. How many of you sitting here have diagnosed a case of RB or have been a part of the team in the evaluation of retinoblastoma, even management? Great, all right. So you have seen the cases, you know what is it about, how to diagnose, how to classify, and the management. That's what we are going to touch upon today, all right? So retinoblastoma, as you all know, it is the most common intraocular tumor of childhood, right? And the most common symptom is white reflex. White reflex, right? What are the other common symptoms that you come across in clinics apart from white reflex? Strabismus, yes. Ophthalmos. Sorry? Nystagmus, yes, because you know the vision is affected due to the presence of the retinoblastoma. Secondary glaucoma, redness, even aseptic orbital cellulitis when the tumor is very large and it has undergone a necrosis. We do have advanced situation where you can have hyphema, hypopaeon, vitreous hemorrhage, all these things. So it is very, very important. This is an easy cut. Easy diagnosis to have a white reflex and then diagnose retinoblastoma. But it can masquerade. This is very important for you guys to understand. When a patient walks in, a child walking in with all these things can have a retinoblastoma hiding inside. So I just wanted to highlight to the young group over here regarding the diagnosis and what you should look for and not look for in retinoblastoma. It is estimated that we have 8,000 cases per year worldwide. And the agony is, out of that, 1,500 to 2,000 cases are in India, in developing country like India and China. So we see more of the retinoblastoma cases when compared to other side of the world. And the good news is that more than 90% of these eyes can be salvaged. And 100% of these eyes almost can be saved if it is detected early. All right, so this is exactly how an intraocular retinoblastoma looks like. Since you have seen these cases, any one of you, can you just tell which group is this now? You know the group, right? Yeah, the grouping of retinoblastoma, the classification? Not really? Anyone gets a chocolate at the end. You get a present. Yeah? Does anyone want to attempt? Yes, please. Sorry? Yes, well, there is a fluid over here, so it's exophytic. So that is a morphological classification. So we have different forms of classification. I'm going to leave this slide here, okay? So let's go on to classification. So this is a quick revision of the classification over here. As he pointed out, there's a morphological classification, which is exophytic, where you have a tumor arising from the retina with subretinal fluid, which pushes the retina. That is exophytic. Endophytic are those tumors which fills the vitreous. Endo, which grows inside. You know, this is like a tumor filling the vitreous. There is lots of vitreous seeds and the entire vitreous is filled with tumor. So that is endophytic. Then you have something called mixed, where you have an exophytic tumor and an endophytic tumor, where the tumor is bursting into the vitreous. A diffuse infiltrating retinoblastoma, where the entire retina is thickened and the retinoblastoma cells is infiltrating the retina as a sheet, as you can see over here. You can see the normal retina over here partially, and this is the involvement of retinoblastoma involving the entire retina, and this is called diffuse infiltrating. There is yet another entity which has put forward in the recent literatures compared to the previous ones. So these are tumors which infiltrates the anterior segment, and the posterior segment is absolutely normal. There is no tumor in the posterior segment, even up to pars plana. So the anterior segment seeds, hypopaeon, and a tumor sitting in the ankle, and this is called the diffuse anterior segment RB. One more morphological form to add onto your list today, all right? So this is the international classification of intraocular retinoblastoma. It's not the recent advance, but well recently we have been always using this form. I remember back in 2009 when I was giving my viva for my postgraduate exam, my examiner from Manipal, She asked me this question. We had a pathology slide, which was retinoblastoma. I chose retinoblastoma, which I was confident of. And she asked me the international classification of retinoblastoma way back in 2009, 10 years back. All right? So you can expect all these things even in your examination, your theory as well as your practical examination, the classification. So it's classified very easily. It's A, B, C, D, and E. Very easy to remember. A stands for small. Any tumor less than 3 millimeters in size. Small for A, all right? And it is at least 3 millimeters from the foveola and 1.5 millimeter from the optic nerve. Now B is for big. Easy. More than 3 millimeters in size. B again is for bubble. It develops a subretinal fluid around it. So a big tumor with a bubble goes for B. Easy, right? Yeah. Now we go on to, so something like this. You know, you have small tumors over here and a big one with the fluid here. Now group C are those tumors which have seeds. C and D has seeds, all right? C means confined. That means focal seeds. If the seeds are within 3 millimeters from the tumor, it is supposed to be focal. So we call it C group. D group are again with seeds. It can be vitreous seeds and subretinal seeds, but it is more than 3 millimeters away from the tumor, which is quite diffuse. As you see in this picture over here, you can see these seeds very close to the tumor, whereas in this eye, you can see lots, this is the tumor, and there is lots of diffuse seeds scattered in the vitreous. So that is group D. Isn't it easy? A, B, C, D, all right? E is for extensive retinoblastoma, extensive intraocular retinoblastoma, where the tumor is filling the eyeball, almost touching the surface of the lens. It has vitreous hemorrhage. It can present with aseptic orbital cellulitis, complete hyphema. There can be phthisis bulbi, neovascular glaucoma, massive intraocular hemorrhage. All these advanced intraocular form comes to the E group. All right? Understood? Thorough? Perfect. So now recently, there has been lots of talks and there has been lots of advanced treatment approach to the vitreous seeds, which has been difficult previously. So there is yet another classification of vitreous seeds now. So these are the spherules, the dusting, and the clouds as it appears. So if it's a spherical vitreous seeds, it's called a spherule. If it appears like a cloud, it's called the clouds. And if it appears like a dusting, it's called the dusting. Very easy. All the classification recently has been put forward so easily to remember. Then comes the staging. So how do you stage? So you have done the intraocular part. Now you want to see whether it's spread to the body or whether it's outside the eyeball. So that's how you stage it. This is for live survival, whereas grouping is for the eye survival per se. So how do you evaluate in staging is by evaluating for systemic metastasis, cerebrospinal fluid cytology. You all know that retinoblastoma, it can spread through the optic nerve to the meninges and then to the central nervous system, right? So CSF cytology and bone marrow, that is for hematometastasis, okay? Hematological metastasis, whether there is anything in the bone marrow. So this is how we stage it. Radiological evaluation, yes, for staging is important in order to know whether it's just intraocular or whether it's optic nerve extension or extraocular, all right? More than that, in children, especially who's presenting with bilateral retinoblastoma, what else do you know? Like, you know retinoblastoma, what else? What is the other retinoblastoma that you know of? Sorry? Pinealoblastoma. So it comes under trilateral retinoblastoma. Well, so can you see this tumor over here? There's a small tumor sitting near the pineal gland, and this is pinealoblastoma. So it's very important to image all these children when they present to you. So how do you image it? Do you prefer MRI or CT scan? CT scan, how many for CT scan? 1, 2, 3, 4, 5, 6, 7. MRI? A huge majority. Why? Any particular reason you chose MRI over CT scan? No reason? Absolutely, all right. So all these most of these children can have germline mutation, okay? So exposure to radiation can cause secondary cancers in the future. So we try to avoid CT scan as much as possible in children with retinoblastoma for imaging. Excellent, thank you for the answer, all right? Yeah, now we go on to the staging system. So according to this, we stage it as stage 0, stage 1, stage 2, stage 3, and stage 4, which includes intraocular component, extraocular metastasis, regional extension, and metastatic disease. So this is otherwise known as a Shantada's classification. I want you all to go and read it. Okay, I'm just going to briefly brush through it. So this is how an oncology practice where a retinoblastoma service is done. These are the things that we usually require: an indirect ophthalmoscope, a 20D, a 30D, a speculum, lots of cotton buds, to depress and see 360 degree of the aura. We do a drawing, and this is exactly how we document in different colors, the size, the location, the seeds, everything. We do a B scan in all these patients because it's easily available. It's the most cheapest mode of diagnostic modality in retinoblastoma, and a ret cam for documentation. Okay, there are certain other equipments that we use. This is how a transpupillary thermotherapy infrared diode laser equipment looks like. And then the third hand of a retinoblastoma practitioner is the cryotherapy. Okay, cryotherapy is, we'll talk about all these things in later. And then this is how we do it under general anesthesia, a 360 degree examination including the aura. We cannot miss tiny seeds sitting in the periphery, not just the posterior part, under anesthesia. And this is how we do it every time the child comes in. So now you know what group this is. B group, excellent. All right, so you have a large tumor over here, and then there is a fluid all around here. Okay, so this is a B group intraocular retinoblastoma. So I'm going to show you how we treated it. So this is actually the right eye of a child who had a bilateral retinoblastoma. The left eye had a large retinoblastoma. In fact, it was a neonatal presentation where it was extending into the optic nerve. The child had to undergo high-dose chemotherapy. That eye was enucleated, and well, we had to save this only eye. We had to reduce the size of the tumor, and we had to give some vision if possible, right? So as you can see here, I'm sorry. So this is the tumor. It's all regressed with systemic chemotherapy, and then we did a laser thermotherapy from here where the fovea is not seen. It's covering the entire macular area where you can see the foveola is spared. Okay, and the child sees. And this is how, this is an artificial eye in the left, and this is how he sees. Okay, all right. So going on to the management. So management in retinoblastoma has evolved in the recent past. You know, we had seen enucleation as the only modality of treatment in retinoblastoma in the early 50s and even 60s. Then external beam radiotherapy. Radiotherapy was used as a mode of management. We no more use radiotherapy as a primary management modality in retinoblastoma. Why again? Radiation, secondary cancers, all right? We don't use it anymore. Systemic chemotherapy and focal therapy was really changed the phase of management of retinoblastoma in 1996, when a series of clinical research scientists from different parts of the world came up with the introduction of systemic chemotherapy. Well, it has to be used along with focal therapy, as I told you, laser and cryotherapy, to consolidate the tumor as much as possible. And then 2000 changed the phase of management. The newer advancement in the management of retinoblastoma came up in 2000 with targeted therapy. Anyone know about targeted therapy? We are going to cover it though. Targeted therapy in retinoblastoma. More than systemic chemotherapy, are you aware of anything? It actually was a short note for you guys. Recent treatment modality in DNB. Yeah. Yeah? Did your seniors tell you that? What is it? The recent management modality in retinoblastoma? Intra-arterial chemotherapy. Excellent. One more? Anything else? Intravitreal chemotherapy. Excellent. Okay. So basically, primary treatment is mainly three: systemic chemotherapy, intra-arterial chemotherapy, and well, enucleation in advanced cases. Adjuvant treatment, which is used along with these primary treatment, are focal laser therapy, cryotherapy, intravitreal chemotherapy, periocular chemotherapy, plaque brachytherapy, and in some situation, if required, external beam radiotherapy. So this is how the management of retinoblastoma goes. So systemic intravenous chemotherapy, the most common protocol which is used worldwide, is the VEC protocol. What does V stands for? Vincristine, E stands for etoposide, and C stands for carboplatin. All right, yeah. So I'm going to show you how the results are. So in the developing countries, systemic chemotherapy really works. Okay, it's affordable first and foremost. We have poor patients coming in. Intra-arterial chemotherapy works wonder, but it's slightly more expensive. So 6 cycle of systemic chemotherapy would be covered in 50,000, never more than 60,000 rupees. That's 6 cycles of systemic chemotherapy, and with very good results. So as you can see here, this is the right eye of a child, where you can see a large tumor in the macular area. In the periphery, at 5 o'clock position, you can see this large tumor which is ruptured into the vitreous, another tumor over here, and this is the left eye with the retinal infiltration, in fact, and the large tumor over here. So this is how it looks like after 6 cycles of systemic chemotherapy. You can see the fovea is again spared over here. The tumor has completely regressed. All the vitreous seeds regressed. This case, in this eye, although it was a diffuse infiltrating retinoblastoma of the retina, the vision is less, visual prognosis poor, but then the tumor is well under control. 2 years follow-up, no recurrence. All right. So this was a case, again, bilateral case, one eye enucleated, only remaining eye. The child received 6 cycles of systemic chemotherapy, but you can see here there is a recurrence of the tumor there. Okay, this happens. After stopping the systemic chemotherapy, these children can have recurrences, and that is exactly why it is so important to keep them under follow-up. All right. So, well, you don't want to give systemic chemotherapy again. Think of giving systemic chemotherapy for this small tumor over here. So one thing what I did was, it is again endophytic. As you can see here, it's slightly bulging into the vitreous. All right. I gave intravitreal topotecan, 3 injections, and the entire thing just faded away. All right. So this is how we treat recurrences. So this is a very interesting case, a very close patient of mine, right eye retinoblastoma at 7 years of age. Okay, you can see this white reflex even in an undilated pupil over here. And this is how the retina looks like. The whole retina is filled with the tumor, a large tumor sitting inferiorly, lots of vitreous seeds, and a ciliary body component over here inferiorly. All right. So 6 cycles of systemic chemotherapy was given to her. Tumor regressed. Intravitreal topotecan was given to her. Vitreous seeds regressed, but then this refractory ciliary body tumor was still lying there. So the father badly wanted to go ahead and salvage the eye. What is the other option? We have done everything possible except intra-arterial, because it's not affordable for them. So it's a focal tumor sitting in the ciliary body area. Anything that you can think of? Yeah? Okay. So what we did was a plaque brachytherapy. Okay, so a plaque brachytherapy is a localized plaque with radioactive ruthenium, which is placed over the surface of the tumor, and it kills the tumor. So this patient received 6 cycles of systemic chemotherapy, cryotherapy, diode laser therapy, periocular topotecan, intravitreal topotecan, and plaque brachytherapy. So why did I give periocular topotecan? Because when the eye is filled with vitreous cells, you cannot actually go and poke the needle inside. What happens? So when you take out the needle, you're carrying the vitreous cells outside. So from an intraocular tumor, I'm going to spread the tumor outside, and that becomes an orbital retinoblastoma outside the eyeball, right? So initially, in order to consolidate the vitreous component, we give periocular, like that's a sub-tenons injection of chemotherapeutic agents like topotecan. Once that's settled, I find there is space, a safe space for me to go inside with the needle. That's when the intravitreal topotecan is given. And you can see here the tumor is completely regressed, and this is how she is with 6/9 vision after all these treatment, and she's doing fine. So intravitreal chemotherapy, the most common chemotherapeutic agents use are melphalan and topotecan, and this is the safety enhanced technique. We go at the pars plana around 3 to 3.5 millimeters away from the limbus with a 30 to 32 gauge needle, and then safe doses are given, be it melphalan or topotecan. My favorite is topotecan because of the reduced localized toxicity. Melphalan is slightly more toxic. So there are, various reports which has come. This is a kind of a review. Many people use thiotepa to start with, melphalan, and there has been an eye salvage which is even reported 94% with the use of intravitreal topotecan. All right. Very interesting case. This is an artificial eye, the right eye. He's 13-year-old now. He got all his treatment done when he was like 4 years of age. 2 years enucleated the right eye. And at 13 years of age, he comes like this. vitreous seed recurrence. So imagine all these patients has to be kept under regular follow-up. You can't miss out on them. It can recur anytime, all right? It can recur, it may not recur. So his recurrence happened when he was 13 years of age. And it was only the vitreous seeds that was there. So the option was intravitreal injection, okay? So he received, and this is how the vitreous seeds were spread. Intravitreal topotecan 4 injection, boom, abracadabra. The entire thing went away, okay? It just melted away, and he's doing fine. So he didn't need another 6 cycles of systemic chemotherapy to beat this vitreous seeds. So although all these new treatment are good to talk about, and it gives extremely good results, but we have to be very, very careful in using this. So we have a safety enhanced technique. Although we go past plana, we don't touch the retina, we go away from at least minimum 3 millimeters away from the location of the seeds. We do cryotherapy, and this is the most important step, all right? We do triple freeze thaw cryotherapy at the site of the injection even before withdrawing the needle, so that even if there is a minute cell which is stuck to the needle, it is cryoed and it's dead, all right? And this is how we do it, intravitreal chemotherapy. Going on to intra-arterial chemotherapy, really quick. It got introduced in 2000 by from Japan, a very famous physician scientist, Dr. Kaneko, and then it got popularized in the West by Dr. Abramson and Carol Shields, who's my teacher. So this is basically a direct intraocular delivery of chemotherapeutic agents via the ophthalmic artery, all right? We have the ophthalmic artery. So a catheter is introduced into the ophthalmic artery, and then you inject the chemotherapeutic agents. So can you imagine the thing happening? Have you seen any videos or anything? Do you know the technique? Okay. Let me quickly take you through this video. This is exactly how it happens. Through the femoral artery, okay, a French catheter is introduced. You can see the aorta, the internal carotid artery over here, branch ophthalmic artery. So the catheter is kept at the internal carotid artery ostium. Make sure that it's there with fluoroscopy, and then after the conformation of the catheter in the ophthalmic artery, the chemotherapeutic agents are injected, but directly goes and hits the tumor and causes the regression and consolidation of the tumor. So this is how intra-arterial chemotherapy works. So this is how in real practice it happens. So they always do fluoroscopy on the table. That's the femoral artery. They find the femoral artery, and then the catheter is passed after making sure it's femoral artery but not the vein, all right? The blood has to come through, arterial blood has to come out, and then the catheter is placed. And then, it's not done by an ocular oncologist like me, but it's done either by a neurosurgeon or a interventional neuroradiologist. They do it in their cath lab, all right? Yeah. So we as ocular oncologists, what is our role is to decide what is the indication of intraarterial chemotherapy, whether this eye can be given intraarterial chemotherapy, what drug to be given, and what dose to be given. So the procedure is done by them, all right? And this is how the results are. Very good results. Small tumor over here after 1 session of intraarterial chemotherapy. Larger tumors after 3 sessions of intraarterial chemotherapy. Again, recurrences, which has been treated by systemic chemotherapy. You don't want to do another cycles of systemic chemotherapy, 1 to 2 sessions of intraarterial chemotherapy. You see the regression over here. A large recurrence, complete regression over here, okay? So how has it changed the management in retinoblastoma? Well, systemic chemotherapy, 95% of my patients that I treat in India undergo systemic chemotherapy. I would say 98%. I do practice in China also, but there 98% of the patients undergo intraarterial chemotherapy. So it's whether you can afford it or not, but the effect is really good. But we have found significant increase in eye salvage compared to chemo reduction in intraarterial chemotherapy, especially in the DIs, which are slightly more advanced. You see, in chemo reduction, if you compare this table, 47% eye salvage, it jumped to 94% from one series, which was in Wills Eye Oncology with Dr. Shields, and the other one from the China, 85%. So there is a large jump in eye salvage in intraarterial chemotherapy in the D group. Well, E group, we usually avoid intraarterial chemotherapy, rarely done. So any new technique, it has a long learning curve. It is associated with minor complications as well as vision threatening major complications. It has to be given with good caution, It has to be done by a person who's an expert in it. So minor complication can be dealt with. Most of the patients present with this, like ptosis, lid edema, a little bit of inflammation, wherever the arterial arcade is there, where we have injected the chemotherapeutic agents. But these are vision-threatening complications which you have to be really, really careful, especially in those children who are like one-eyed. You don't want to make them blind with a choroidal atrophy or a CRA or a vascular thrombosis. So you have to be very careful in choosing whom to give intraarterial chemotherapy. Another thing is you have to always suspect danger. These are absolute no for intraarterial chemotherapy. It's systemic chemotherapy. You can see a large, swollen eyeball over there. You can see the tumor right there. Never go for intraarterial chemotherapy. Either you enucleate or start with systemic chemotherapy in order to circumvent and prevent systemic micrometastasis. So this is a child who actually got intraarterial chemotherapy one session, all right? And then identified, enucleation done. You can see this after enucleation specimen, there is an optic nerve extension. Well, this child might die if she continues with intraarterial chemotherapy. So that is about enucleation. So you have to actually take a stand when to enucleate. Although you have all these good treatment where you're doing extremely well with eye salvage and vision salvage, there is a particular point where you have to take a decision, well, this eye is going for enucleation. And enucleation, there is again certain steps and technique which has to be taken care of, mainly the optic nerve length, all right? So you want a long optic nerve stem because you don't want to have a positivity at the transection. If you take a lesion from here and there is a cut from here in the optic nerve and there is a post-laminar extension, you're having a positive transection of optic nerve, which is really bad. It can have CNS metastasis to the optic nerve and the dura, all right? So pathology, you all know it. You have to go and read about it. It appears like a cottage cheese. So small, round, blue cells. Retinoblastoma is small, round, blue cells. That is what you see. Then you have the homocyte erosets, you have the flex nerve intestine erosets, and the fluorids. So these are the characteristic diagnostic pathological features in retinoblastoma. More than that, what we need to be aware of is the high-risk features. After you enucleate, the eyeball should not be just sent and left over there. You have to go back with the pathologist and find out what are the high-risk features which is present, whether it's present or not. And these are, most importantly, massive choroidal invasion, retrolaminar optic nerve extension, optic nerve transection positivity, scleral invasion, and extrascleral extension. Why? Because even after enucleation, the child can die, because these are the risk features for systemic metastasis. All right, so what do we do after that? These children have to receive adjuvant systemic chemotherapy to circumvent the spread of tumor into the body and to the brain. All right, so if there is a clinical risk feature present, histopathological risk feature present, they undergo a metastatic workup, as I told you before, with CSF cytology and bone marrow biopsy, and then we initiate 6 cycles of adjuvant chemotherapy. So never shy away from enucleation if it is really required, but you have to make sure they are cosmetically rehabilitated. We don't do enucleation without an implant, okay? The most common implant that most of us use in India is PMMA implant, which is very cheap, 350 rupees for an implant, okay? So that's how we put, and a customized ocular prosthesis. So you can't even make out which is an artificial eye in this case, right? So it's very important for the parents. It's so difficult to convince them for an enucleation. We have patients who have run away. When you tell them enucleation, the parents just run away. And then they come back with an orbital retinoblastoma. So you have to sit with them, convince them, show them, how the outcome is going to be, and then it's possible, all right? So this is a child with a history of white reflex. So what is this now? Orbital cellitis? What does the baby have here in the right eye? Proptosis, right? So whenever a child with a history of white reflex comes with proptosis, what does it mean? When do you get proptosis? Anything in the orbit, right, has to push the eyeball forward. So that means there is an orbital extension of this intraocular retinoblastoma. So this child, this is how: cataract, advanced intraocular retinoblastoma, and the tumor has ruptured inferiorly through the sclera to reach the orbit. And this is how radiologically it looks like. It almost fills the orbit here. Luckily in this child, the bone marrow biopsy and CSF cytology was negative. Okay, if CSF cytology was positive, prognosis is almost 100% mortality. But if it's bone marrow positive, we still have a hope that this child will survive, all right? So orbital retinoblastoma, there has been certain changes in the management, which has been extremely, extremely useful for saving the life of these children. It is classified as primary, secondary, accidental, overt, microscopic. I'm not going into the detail. So earlier, the management which has been adopted was exenterate the orbit, because it's in the orbit, you exenterate, but the mortality rate was 100%. Radiotherapy alone, 100%. Then they combined radiotherapy and adjuvant chemotherapy, but still 70% of the children died. So Dr. Hunawa had put forward a protocol in treating orbital retinoblastoma that we all follow. And then this is the case series and the result of these 40 cases that we evaluated, 90% survival. I'm almost done, less than 1 minute. So this is how the protocol is: high dose chemotherapy, enucleate that eye once it becomes thicical. External beam radiotherapy is used in this situation where you want to kill the local tumors, if at all it's remaining microscopically, and completion of high dose chemotherapy, 12 cycles, all right? So this is after 1 cycle, 2 cycle, 3 cycle, thysis bulbi. It is at this point that you enucleate. Another case, optic nerve extension up to the apex, regressed after 9 cycles, enucleation, and well, he's got a prosthetic eye over here. So this is again the last case, a child who presented with one eye thysis bulbi and the left eye orbital retinoblastoma when she presented to me. Unfortunately, she underwent treatment, both eyes are enucleated, both eyes are prosthetic eyes, but 3 years after, you know, she's doing extremely well. So this is when she visited our service on her birthday. So more than everything, there is a very deeper bond that we share and have with our patients also, which is very, very important for the patients as well as the parents. Last thing, this is an father who has bilateral retinoblastoma. He never knew that his child can have retinoblastoma in future. He was not aware of it. You all know that retinoblastoma is a genetic disease, right? So there is so much of unawareness in the society, and this has not been even articulated and told to the father by a physician that your child can have retinoblastoma when he is born. So this child had bilateral retinoblastoma like his father, who has undergone enucleation and radiotherapy. So genetics of retinoblastoma is again very, very important. There has been breakthrough research in genetics of retinoblastoma recently. As you all know, it is RB1 is the first tumor suppressor gene which was discovered, and it's an RB1 gene mutation that happens in retinoblastoma where both the alleles are affected, and the MYCN amplification is yet another form of genetic mutation that has been recently found. So there are centers in India which does genetic testing for retinoblastoma. Dr. Usha does a lot of work in genetics in retinoblastoma at Aravind Eye Care at Madurai. So, you know, anyone can send samples and get the genetic results of these patients, which is very, very important. So just concluding, you need to know the most common symptoms, the masquerades, what are the treatment modalities available, radiology evaluation, and the new modalities, when to use it and when not to use it. Always the mission in retinoblastoma management has been saving life primarily, secondarily the eye, and tertiary the vision. Thank you so much, and thank you for your patience.